So good morning, everybody. Thank you for joining us. And we'll just do brief introductions. We'll get into the panel discussion. Panelists, this will be more fun if we're very interactive with each other. So feel free to ask your own questions and comment. Right next to me is Dr. Mark Wright, who is the Director of Research for the Minneapolis Federal Reserve Bank. Nope, right there, excuse me. This is Dr. Laroche, Medical Director for Addiction Services, Allina Health. He was trained here at the University of Minnesota and joined Allina in 2016. Claire Wilson is Assistant Commissioner for the Community Supports Administration, Minnesota Department of Human Services, and we've all met Dr. Kelly. So I think I'd like to start with just a very top-level kind of conversation. Vast topic. We could talk all day, obviously. What I'd like to know, Mark, what impact is the unfolding opiate addiction crisis having on employment and economic vitality in a region?
Yeah. Thanks, Lee. So the Federal Reserve has been charged with the responsibility of trying to generate maximum employment in America. And so in order for us to do that, we need to understand what that means. And I think the opioid crisis and addiction more generally impacts that in two ways. First is that, when we look at unemployment rates, unemployment is at a very low level, both here in Minnesota and nationally. But when you look behind that number, we see there are lots and lots of Americans who are not working, far fewer who worked, that used to work maybe 10 years ago. And when you look at the people who aren't working, you see that many of them are taking pain medication daily. In fact, if you look at prime age men, half of them are taking some kind of pain management, who are not working, by the way. Half of them are taking some kind of pain management medication each day. And so the extent to which that leads to addiction and prevents them from being able to work is something that impacts the way we set monetary policy. On top of that, if by stimulating the economy we can create more jobs, we can create more openings for people to find employment, to reattach themselves to social networks, if we can encourage firms to increasingly waive criminal records requirements to remove some of the barriers for people with addiction to find jobs, to, as Dr. Kelly described it, issue more of these building permits, then by monetary policy, we can actually help resolve this crisis. And so as we think about setting monetary policy in the future, that's something we need to take into account.
A quick follow-up question is, as part of your work at the Fed, I know the Fed goes out and talks to employers and others in the district. How would you characterize awareness of the opiate crisis among employers that you all talk to as normal course?
Yeah, so we hear about it quite a bit. At the moment, most employers are reporting problems finding people to work, or at least finding people that they think are reliable to work. They're increasingly looking to hire people with criminal records and waiving those requirements because they're increasingly desperate to find people. But they're also wary of hiring people who might have some addiction problem that might interfere with their ability to work. So it's very much weighing on their minds. I think that firms are beginning to look at this and trying to think about what they can do to perhaps help and find more employees, but it's still a limitation in their minds for many of them.
Okay, so Dr. Laroche, I know in your work at Allina, you interact with payers, right? People paying the bills are employers and employer groups. I'd like to hear your perspective on awareness among employers, where this might stand today.
Yeah, I mean, it's a good question, and I want to say thanks very much for setting this up, because your question relates to how important it is that we do have discussions and dialogues like this. Having an opiate use disorder is kind of something that's been around since the millennia. I mean, way back in China, the opium addicts, and the old people that would be smoking opium, it's been around for a long time, and it's been in America. As a matter of fact, it became a problem during the Civil War, and when you hear the expression kicking the bucket, it refers to those people that were soldiers trying to get home and withdrawing with such cramps they'd kick the bucket in their cells. So it's been around a long time. The reason we're recognizing it now is because it's affecting all of us individually. It no longer knows financial bounds, racial bounds, gender bounds. And so similarly, your question about payers are kind of behind the eight ball, but in sync with what our society has been. We 10, 15, certainly 20 years ago would say, you know, no one really in my family struggles with an opiate problem. And so payers were able to say, we don't pay for it because no one put pressure on. Only recently do we now recognize the pervasiveness of opiates. And payers are always several years behind. So I'm not blaming them. I'm not blaming anyone. I'm just saying payers have had an excuse to not pay. And they're very comfortable currently in not paying because it's been the trend for the past 50 years that we've had depression or had insurance. That is changing, but every layer of payers, be it private insurance, be it Medicare, Medicaid, there's all types of stipulations, and paying for inpatient but not paying for outpatient, which is a biggie. And you know, the focus of this symposium is recovery, which is less covered than any other aspect of the opiate disease, which has to change. But gatherings like this is what's going to help bring the change. And I just want to thank you for hosting this and everyone here, because it has to change, because it's affecting our children and our spouses and our best friends.
Commissioner, would you like to jump in here? The state, of course, is a big provider of services and also has other policy considerations. What other resources being allocated currently to responding to the crisis?
Thanks so much, and also I want to echo the thanks for putting this on and for you all being here, and for Dr. Kelly. That I was very validated from a state's perspective, because I do feel like we're doing what he was talking about. Though, as a 43-year-old recovering alcoholic, I just kept hoping there was going to be another slide with the hole in the brain shrinking after recovery. So I feel a little naked that I'm actually 43 and that hole might be in my brain. So don't quote me on anything that I'm about to say. No. You know, so the state has really, in the past couple of years, started to embrace, through our policy making and through the expansion of the Medicaid program, really embracing moving treatment away from being episodic, away from that burning house, into a longitudinal model of care. And so just last session, actually, at the Capitol, the legislature did appropriate and approve a package that is actually the most significant SUD reform that we've had in a very long time, and which included bringing into those services that could be reimbursable peer recovery supports, care coordination, direct access to treatment, withdrawal management. So we really are pushing, from a state's perspective, moving that system to being more longitudinal, and really, you know, that beginning to require that payment be provided for these services. Because as we know, and I do want to bring into this space just some really Minnesota-specific statistics, and in particular name the vast disparities in terms of our opioid crisis here in Minnesota. So we do, in fact, our treatment admissions are primarily for alcohol, they're by and far, with meth being the next, you know, closest right now and rapidly rising. But as you all know, and as Dr. Kelly mentioned, we are far more likely to see opiate deaths, you know, so you're far more likely to die from your addiction. But if you're an American Indian, so in 2015, if you were an American Indian, you were 5 more times likely to die from your addiction. If you were African American, you were 2 more times likely to die from your addiction. American Indians in Minnesota make up 1.1% of the population. They make up over 15% of our treatment population. African Americans make up 5% of our population. They make up over 10% of our treatment population. Neonatal abstinence syndrome, again, that's 5 times more likely in the American Indian community, and 80% of neonatal abstinence syndrome, you know, infants are born to mothers on Medicaid. So I just really want to bring into this room that the disparities, particularly in Minnesota and particularly around this crisis, are incredibly alarming. But moving all of these services into the Medicaid program, we hope, will move us closer to really this community of supports, which Dr. Kelly was saying help people achieve long-term recovery.
Thank you for that. In the upcoming, you know, sort of legislative policy-making season, are more resources going to go into this area? Is your sense? I know it's hard to forecast or handicap. What is your sense?
Well, we know that the governor is, and the legislature are prioritizing more investment into the crisis. I do hope. I mean, of course, I'm from the policy making arm of the government. But we are going to be working with advocates, elected officials, and others to assure that there are more dollars invested. At the federal level, of course, Minnesota just received $10.1 million for 2 years. Those are going out in the form of state targeted response grants. So that's 30 grantees across the state. Again, there's a disproportionate impact of this crisis in rural Minnesota. So making sure those dollars are going to increasing Medicaid assistant therapy and naloxone and emergency response and all the different prongs that we have to see. But I do expect that the legislature will appropriate more dollars for this.
Thank you. I'll just keep going with my questions. If you have questions for each other, please pop in here. But one of the things I'm curious about is I think opiates is behind alcohol in our understanding of recovery. I mean, we've known people in AA. We've seen this in the movies for generations. I don't know of people in a similar organization with opioids. Is my layman's sort of sense of the world accurate? Dr. Kelly, maybe?
Yeah, there are lots of similarities and some peculiarities, differences specific to opioids. One of the things with opioids is that most of the people that we see tend to be on the severe end of the spectrum. So it's unusual that you get mild, moderate forms of heroin addiction, for example. Once you're into that category of having a heroin use disorder, you tend to be in the severe category. It's that type of a drug, whereas with alcohol, you tend to get a spread. You still get the severe end of the spectrum, and these are the folks that end up in treatment. We still see the highest rates of treatment use, of course, for alcohol, and the highest rates of addiction for alcohol. But we see similar trends in terms of that timeline I showed you. The progress that people make, there's been Yi Asur and Doug Anglin at UCLA have done these nice long-term studies of opioid addiction up through 30 years, show the same kinds of relapse recurrence and short-term remission leading to longer-term remission over time. One of the things that we have in the toolbox for opioids, which works very well, is opioid medications. So things like methadone, Suboxone, buprenorphine, naloxone, and injectable naltrexone. These are shown to be effective and actually can help people over the long term also. We have people in stable remission who've been on methadone for a long, long time, decades, going to work, functioning. We've seen with recent studies with opioid addiction on Suboxone with 2/3 in remission at 4 years after starting Suboxone. So these are good outcomes. Again, we see the similar rates of remission through slightly different pathways.
Thank you. We talked briefly about awareness. Dr. Laroche, I have a question for you, and that's about medical practitioners, oral surgeons, GPs. 5 years ago, I had a trivial procedure, and I got, I think, 15 pills. I used exactly 0 of them. What is the sense among practitioners more broadly, sort of catching up to the opiate crisis?
Well, that's a great question. And it opens up a broader door on the whole field of addiction. Addiction really knows no bounds. I might be addicted to alcohol, and I'm much more likely to become addicted to pornography or to methamphetamines. Addiction's addiction. It matters primarily about the substrate. Just like obesity, people had the gene of obesity 100 years ago, but there wasn't enough food or substrate. And so actually obesity was very self-serving. People who were able to have a little bit of food and gain weight and store it better survived and had healthier children. So similarly, your question about alcohol and opiates, there's a lot more alcohol around. You could go anywhere. Every household has it. And that's why alcohol is a far greater problem. If there was as much opiates would be a far greater problem. As a matter of fact, in 2016 versus 2001, there was 4 times more prescriptions 4 times more prescriptions, and 4 times more death. It's not a coincidence. It was almost to the point how much more death. The more opiates there are, the more people are going to experiment. 10% of all high school seniors dabble in opiates every single month. At least 1 to 3% of adults dabble in opiates every single year. At least 2% have an opiate problem. So we're saying it's there, and the more that it's available, like your question about when it's prescribed more often, it's going to be a bigger problem. Physicians are now held more accountable because this is a problem. It was no one anticipated the breadth of what would go on. I mean, in Minnesota alone, there was over 600 deaths just in 2016, or excuse me, 2017. But there's more than 2,000 near deaths. I mean, this is what we don't realize. We're talking about the tragedy of the deaths, but I mean, 2,000 that were not fatal. So it is something that we sometimes can go under the rug because, you know, there were 2,000 that did not pass away. But it's a very real issue. And physicians now, healthcare providers are now recognizing that there is an association with the more medications available, the more likely someone will use it. And to that point, some of the differences, you know, alcohol is a depressant. If we put an IV in our arms and we're infused with high doses of alcohol, every one of us would eventually develop a depression. But you know, like we saw from the outstanding slides from Dr. Kelly, that sometimes opiates the opposite. When people remove their opiates, their mood starts to go down and they start to experience a year, 2 years, 3 years of intense dysphoria. The question is, sometimes people had that dysphoria before they even used. And there are people, I can use myself as an example, that just using one opiate, one pill, there was like magic that happened. So sometimes we fall into alcohol if we have a little more anxiety, or opiates if we have a little more depression. Sometimes it doesn't matter at all, but I'm just trying to say there's a huge overlap, and it is very critically important that we regulate the supply that's available out there.
Okay, so Dr. Laroche, in looking ahead at 2018, what are the priorities for the care systems, the Allina Health? What are things that you all are considering a priority this year?
Well, you know, the CDC has been working nationally on initiatives to try to address that very question. And so physicians are more aware now, even compared to 2 years ago, for mandates that require limitations on prescriptions. You know, I think the example you gave was someone, you had an illness and they gave you 20 pills or something. I don't remember how many you said. But there was a time there was a time that they absolutely give it, and it was the desire to try to treat pain. But do you know, by the way, if anyone uses opiates long term, they would develop pain, because the pain receptors are covered by opiates. So the body is trying to help and says, oh, wow, the brain, you can't receive input from the body about all the pain from walking or sleeping. So let's make more pain receptors. And really, sometimes there's 100-fold times more pain receptors in the brain after chronic exposure to opiates. So there are people who had maybe some chronic pain in their neck, get on opiates. 15 years later, the pain is no better. And I'm sure some people would have family members that fit the picture. And also, they'd say, I never used to have pains in my knees and my shins, and now chronic headaches, pain everywhere. So initially, care providers were thinking, oh, let me treat the pain. And, you know, physicians were earlier not giving enough concern to pain. Pain was minimized in the health field, and physicians were encouraged to treat it as a real entity, which it is. It went overboard. And now, because of the CDC and organizational limits, physicians are encouraged to give no more than 3 days' worth of pills. The person has to come back to the office, no more than certain amounts. And so there's much more, especially even just in the past year and a half, much more awareness and initiation in that.
Okay, just generally, if we want to talk about awareness, you know, broadly, you know, what are some things that the state can do? What are some things that other organizations can do to increase awareness of recovery efforts? I think we're generally aware that it's a big problem, but we might not be aware of where the recovery services stand. So what are some things that organizations are doing or need to do to address that?
Sure, I can speak a little bit to that, and then feel free to talk over me. You know, I think there's a couple of things. We are launching through the state targeted response grants a major media campaign, awareness education campaign. The gist of basically which is this is about all of us. And so do hope to highlight some of the recovery community through that. But I do think that a big piece of this is that as larger systems and the Medicaid program recognize recovery as a key component in the treatment system, it will become more, more part of our understanding of how you treat the disease of addiction. And, also as we work with our tribal partners, work with our culturally specific providers, and continue to provide through what we now have in terms of grant funding and innovative funding, really working with those communities to help develop culturally specific, community-specific treatment and recovery components. Because really, that slide was so powerful of Dr. Kelly's that, distinguished between the two profiles, the two clinical profiles. I mean, as we move towards a more person-centered recovery treatment system, I really think we're going just by virtue of, in the same way that there have been, the pink ribbon campaign for breast cancer and red ribbons for AIDS. And I mean, as we become more a part of healthcare, as we grow up through our advocacy efforts, I feel like the recovery component of this is going to become more a part of our just, daily conversations about, just in the same way that that chemotherapy treats cancer, I hope that pretty soon we'll know that recovery coaches help treat addiction.
Yeah, I mean, at the Fed, we're not really in a position to speak to the local activities, but one thing I think we're trying to emphasize is that, these activities are going to cost money, going to cost billions of dollars, and that seems like a lot, and recent developments at the federal level notwithstanding, money seems tight to a lot of state and local governments. And I think to put it into perspective, though, what we need to do is emphasize just how staggeringly large the benefits of getting involved in these things are. I mean, even if you just narrowly define the costs of the crisis in terms of the effects on the healthcare system and on the criminal justice system, this country's spending $50 to $60 billion a year on the crisis. And that's only really looking at prescription drugs, not including some of the non-prescription addictions. Once you include the cost to the economy of people not being able to work, it gets larger still. And then you add in the costs of the death and the devastation that it causes, it's very easy to get up to estimates in the order of $500 billion per year of costs that it's causing us. And that's a lower bound, because that doesn't even include the effect on the families of the affected people. It doesn't include the costs of this on children born with addiction who are having to deal with neonatal abstinence syndrome. It doesn't even include the costs of the kids who grow up in these stressful environments who are forced into the foster system. So, I mean, the benefits of dealing with this crisis are staggeringly large. So even though the costs seem big, it's actually a really good return trade-off. I mean, this is a really good investment for the government to be involved in.
Can I say something also, just along those same lines? Because, the big emphasis right now at the federal level is on infrastructure spending. And we heard recently, a $200 billion investment to create $1.5 trillion in infrastructure spending. What's the purpose of infrastructure spending? To increase the safety and well-being of Americans. Now, we've got a public health crisis which is killing 100,000 people from alcohol, another 63,000 from overdose deaths. And there seems to be a disconnect in terms of public health infrastructure spending. We've got this right in our face right now, and yet who's talking about that level of infrastructure spending for public health? We've got more people dying from both motor vehicle accidents and gun deaths combined every single year, and it's growing. And yet the infrastructure spending that's a kind of a sidebar. Oh, we'll give a couple of billion for addiction. That seems like a lot. But in the face of a public health crisis like that, it seems like there's a huge disconnect. And absolutely right, not just in terms of death and disability, but lost productivity. That's the biggest contributor to this burden and to economic burden. of roughly, anywhere from 500 to 700 billion from alcohol and other drugs each year that we're losing. The largest part is people not going to work. But I think there's a bigger disconnect, isn't there, in terms of infrastructure and from a public health standpoint, public health infrastructure, with addiction right in our face every single day, that we're just not appropriating sufficient funds to deal with it.
Thank you for that. Something to add?
Well, I was going to add, the number one cause of death for all of us Americans, 50 and under, do you know what it is? I'm just, because you're doing all the talking, I just thought I'd ask. Yeah, okay. It's opiate. It's opiate causes, the number one cause of death. So exactly what we're saying, if we don't recognize it as a crisis now, we soon will. The numbers are out there, and they've changed so dramatically in just like 2 to 3 years that we can't keep up. Our knowledge can't keep up, and our funding is having trouble keeping up because it's now really reached crisis mode.
Thank you, panel. I think it's time for questions from the audience. Do we have a mic runner? Please, the mic runners, identify themselves and fire away. Try to address a particular panelist if you could, or just generally to everybody. That's fine, either way.
Yes, David Parker, I'm from Serve, Minnesota, and I think this question is probably for everybody, but maybe I'll direct it to Dr. Kelly. I think one of the big new ideas for me, at least, was that the science seems to be bearing out that there's a social aspect for evidence-based recovery treatment, and I think that was nice to see. It was neat to see. So I'm wondering just kind of what we can do, Joe Public, to amplify that, to talk about that, because I think that might be something that people need to wrap their heads around, just how evidence-based that is. It seemed like that was the theme that was kind of being shown over and over again.
Yeah, I don't mind taking that first. Is this notion of the social networks, and we know there's lots of psychosocial theories about the onset of substance use disorder, and it looks like the same psychosocial theories can help us understand the pathways out of addiction and into recovery. We know that social isolation is as bad for us as smoking. There's been meta-analyses now that conducted that isolating ourselves actually is bad for our psychological but also physical health. And what we know, and these studies are demonstrating that at neurobiological levels, at psychological levels, they help get people into recovery and sustain recovery over time. As you think about it, the connection with others, when you look at groups like 12-step groups, for example, the connections, the friendships, which are very rewarding for people. It's that reward that people need. They need to find a substitute reward. And our reward pathway in the brain was developed in large part, actually, for social engagement and this interdependence, because as a species, we do much better when we rely on one another in groups. And it is. In terms of getting that message out, I think it's a matter really of getting the evidence out in front of policymakers. Often we hear, again, it's the notion of putting out the fire. Putting out the fire is very important, but in Massachusetts, for example, there's always this call for more beds. We have more beds, we need more beds. Yeah, we do, but also let's talk about what happens when they're standing out, off the bed. What are they going to do then? And what we know about the clinical course, that people are susceptible to relapse for many months and many years after. So how can we sustain remission? And it's really through the social connective tissue, the recovery-oriented systems of care. And I think in relation to this, I'll shut up now, but is greater surveillance of what's happening in the country. Much better surveillance, both locally, regionally, and nationally, in terms of, are there pockets of vulnerability, communities that are particularly susceptible? We know this to be true, and there we can actually start to implement greater recovery resources, and then we can measure that change, and we can look to see in a cause and effect way what are the things which are actually making the difference, and that's something that we need to do more of.
Can I just add one thing to that, which is that there are a number of trends in society that I think are going to make this worse over time. You know, people are having smaller families. We're less connected to our families. We don't live in those 3-generation families anymore. People go to church less. They belong to community organizations less. Bowling leagues are getting smaller. All sorts of social interactions are getting smaller. And people like Bob Putnam, calls this the bowling alone phenomenon. We just don't have the communities that we used to have. And so given that that's the case, I think we have very fertile ground for this problem to grow, and that makes it even more important that we be thinking about how to deal with it now.
Bill Manager here. I have a question for John regarding the benefits of drug courts and other incentive-based programs. Do you have any data on that?
Yeah,
Dr.
yeah.
Kelly,
Actually, very good data. So when individuals who come into contact with the criminal justice system are in drug courts, when they're monitored over time, when they are given the choice of incarceration or treatment, they have much better outcomes. In fact, we've done studies in the VA and elsewhere in large cohorts looking at the degree to which when patients are mandated to treatment, they actually have better outcomes than people who are more volunteer in terms of volunteer entry. And when we look at why that is, so they're more likely at 2 and 5 years after treatment to be in remission and to be employed and less likely to be arrested is because they're actually less severe than the more voluntary patients. So they're less sick than the voluntary patients, and they actually have better prognoses. So the intervention that's provided it's kind of an early intervention that can be provided by the criminal justice system to get them into treatment and then monitor their treatment exposure. Actually, when you look at them over the long term, they do better. So that monitoring, we see this also, the monitoring, the oversight that can be provided by criminal justice in terms of getting people treatment, but also we see it in the physician's health program. So physicians who are addicted, who get into the physician's health program, they have 80% remission over 5 years for a substance use disorder. 80% remission. Why is that? They're being monitored, they're provided treatment, they have to go to recovery support meetings, and this kind of configuration, the monitoring and recovery support, can produce 80% remission. That's extremely good.
Hi, Elizabeth. I was just wondering if you could maybe go back to some of the discussion from the previous question. I think one of the challenges as a society is opioids are often viewed as a metro problem. I'm from rural America, and I wonder if you could just touch briefly on kind of the challenges with isolation, particularly in rural communities, and the possibility of technology helping us bridge that divide. Is there evidence to show that technology can help connect peers, and is that effective even with kind of an aging rural population?
Okay, I'll give my perception of it. What you said is exactly true, and I loved what Mark said about the bowling leagues are getting smaller. And, people are moving more often, so when you move, no one knows their neighbors, and you're not with your mom and dad and grandpa. And you have less kids, and they go to school, and the kids don't know. So we are a very isolated society. Might I suggest it's really, really effective to join a group online, but you could join groups on letters. Just to really be part of an interaction with humans is very important. And it is one of the predisposing factors to both relapse and initiating the problem is loneliness. Might I add, though, that, and this is a very important point, you know how the last slide was let's treat addiction like a disease. Can you tell me one disease that's not treated with a medicine? Yes, there are probably some, but be it lupus, be it GERD, be it arthritis, be it diabetes, be it hypertension, think of one disease, there's medicines. And my point for saying that in answer to the question, if you are struggling with an underlying psychiatric condition that's not diagnosed, it is always worse if you're isolating because no one sees how anxious you are or how really bad the depression is. And there's a lot of us who have depression, but we still have to function. We still have to feed our 2 children and go to work as a single parent. But when we come home, we have had it. It's all we could do to just hold up for the day. So I'm just trying to say, being with more people is imperative, especially if they're people that can be very sensitive to how our condition is. To say, you need to get this treated. And, you know, people that struggle with opiates, more than 50% of them have diagnosable concurrent mental health problems that should be treated with the medicine. And so those people, if left alone, will be even worse off because of the psychiatric condition, which of course is one of the top, if not the top, reason for relapsing. The drug is actually treating an underlying psychiatric condition.
So yeah, I'll jump in there and speak specifically to that. So I named out the disparities in terms of the cultural groups, but the rural counties of Cass, Clearwater, and Monoman have the highest rates of use in the state. And then they also are in the top 10 highest counties in the, for percentage of treatment admissions of opioids following substance use. So, you know, a piece of this is clearly that assuring that not only is there availability of medication-assisted treatment or opioid treatment programs in those areas, because if you look at a map of our treatment providers, we have an alarming lack of treatment providers in, you know, areas outside of the metro. But then also assuring that those treatment programs do have the behavioral supports within them so that people are accessing both, you know, treatment for their mental health needs as well as for their addiction. But also, I think another piece of this is encouraging regional responses to the crisis. So really assuring that we're getting the right level of flexible funding out so that law enforcement, emergency response teams, churches, nonprofits, you know, whole communities can come together around this and help to plan their response to the crisis. Because, and including drug courts. I mean, once, you know, we really need to assure that the response can be flexible enough to look like the communities where it's happening. All too frequently, we design a way that works in the metro and then move it out into the rural areas. And in this instance, that's not going, and maybe never, is that an appropriate response, but really assuring that we're allowing for the right level of regional coordination is one of the primary impetuses behind the funding being dispersed in those areas in that way.
My name is Howard. The question that I'd like to ask the recovery community at large is, how do we have a responsibility, and can we find a way to shift some of the energy and the monies to the prevention side? And not, I mean, there's a part of me that says as an LADC that I'm on the wrong side of as a career path. I'm helping people who have already crossed over into addiction. What can we be doing to prevent the house from burning in the first place?
You know, 101 answers to the question, but heralded above them all is knowledge is power. It doesn't matter what the disease or what the social situation, knowledge is power, and it is imperative that we have the knowledge and we spread it to everyone around us. We really don't know who we're impacting. An example you gave, you may tell your kid, who in turn will tell 10 of his friends, one of them will tell him, it's imperative that we get out there and spread the message that it can happen to any one of us. It does happen to every family in America. It's more likely to happen if there's underlying psychiatric conditions. And for those who are in recovery, it's imperative to understand there are medicines that help treat this too. So you don't have to sit and struggle for the 1 to 2, 5 years. There may be a better way. Knowledge is power is what I'm trying to say. We got to get that message across.
Yeah, I mean, I think we know also, I mean, 90% of addiction starts before the age of 18, 50% before the age of 15. Your point is extremely important, and something, you know, I think we've got an inherent human bias where we like to cure people, and we get a great deal of reward and satisfaction from curing people, but we don't get as much reward and satisfaction from preventing something that could happen. And I think we're all got this inherent bias, but you know, the old adage, you know, an ounce of prevention is better than a pound of cure. It's absolutely common sense and rational. And when you look in the population, we've got great epidemiological studies now to show that the onset of these disorders peak in late adolescence and young adulthood. And we've got studies that show also that early intervention, even if we just begin that conversation earlier, it can destabilize emerging addiction patterns and shorten the time to remission. Mike Dennis has done some nice studies that show that if you get treatment, some kind of intervention in that first 9 years when you start substance use, just beginning that conversation, you get into remission 7 years earlier than somebody who doesn't get any kind of treatment exposure. So just like other kinds of illnesses, substance use disorder is responsive to early intervention. So we need to do a much better job at addressing adolescents and young adults, and that's where we need to be, I think, if we're serious about having a dent from a public health standpoint. In Massachusetts now, we've got mandated screening in schools, in all schools, unfunded mandate right now, but I think the funding is going to be coming. But the idea is to screen kids right across the board in the place where they're at, which is school. Of course, this is a contentious issue because this is outside the purview typically of teaching and those institutions historically. But from a public health, broader public health standpoint, that makes a lot of sense.
I'm John. I'm with the retreat here in Minnesota, and thank you all for being here. I'm always reflecting. I've been in this field for over 40 years, and that there's a power that exists in the community that if you can bring people together to help support each other to recover, you can help a lot more people for a lot less money. And Dr. Kelly, you talked about all of the elements of that in terms of creating a social microcosm that elevates people to a healthy, sober, happy, fully engaged life. And I think that that's where you're going to get the most bang for the buck in terms of helping save lives. Oh, what do you think about that? Enough about me. What do you think about me?
I think that was beautiful. When Mark was speaking about the billions of dollars it's going to cost, I was thinking about when we put together our reform package for the legislature last year. And when you do that, of course, for those of you who aren't total policy nerds, you have to put together a change page, right, representing what the impact on the state's budget is going to be if you institute these new programs and benefits. And it was a major reform package, which typically, despite the title reform, ends up costing or, involves a lot of state investment to move a system in that way. When we put together this particular change page, as we were making the assumptions around what would happen if an individual got the right level of service at the right time, so including services up front, care coordination, peer support services prior even to having a treatment episode. If there was direct access to treatment, so meaning you didn't have to come in, get an assessment, and be told where you were going to go receive treatment, which is how our placement process works right now. And then if after that episode of intensive treatment, if that's in fact what where you chose to receive your treatment, then you receive care coordination, peer support services. And if we designed withdrawal management with a similar person-centered, medical model, then in fact, when we made those assumptions, we were able to offset the cost by the savings to the overall system. We were able to prove that in a change page to the state legislature. So I think that it's an absolutely valid point that when you make these investments in these services across the continuum in a strengthened continuum, then you do in fact end up saving money, at least in terms of the treatment system. Now, of course, we can argue at great lengths, and I frequently do in front of the legislature about the savings to our society as a whole. But it's a more difficult argument to put numbers, to attach numbers to. But strengthening the continuum of care, it is absolutely true that if you do it with a recovery mindset, you save the treatment system in the end, the dollars, and just coincidentally people's lives. So.
My name is Peter. First of all, I want to say thank you very much to the panel. And Dr. John Kelly, I found your presentation riveting. I learned a lot. I have a question. I've actually had this question for quite a while. I've seen various reports about the efficacy of Alcoholics Anonymous, comparing, contrasting it with other modalities, et cetera. My question is this. I'm a recovering alcoholic. And for 15 years, I went in and out of the rooms, okay? I went to meetings, I talked the talk, and I never did the program. There's a program in Alcoholics Anonymous, the 12 steps that you need to work in order to get the results. What I found out in 15 years is that most people just go there and they don't do that program. And I think what I'm wondering is, these numbers, are these derived from people who are simply going to the rooms? Or are these people who are doing the steps? Because those are two different things. I mean, I can go and hang out at the gym for a year, okay, and never use the equipment. And then at the end of the year, I can blame the gym and the equipment for not getting me in shape, but I never used it. And that's what I'm wondering. These numbers, are these derived by people who are actually doing the program? Thank you.
Well, we've, as I mentioned, we've got a lot better data in the last 25 years. We're just doing a systematic review right now, Cochrane review, which is the most rigorous type of review you can do in clinical science. And I can tell you that what we're finding, now most of these studies just look at attendance. They're not looking at active involvement. But even with just attendance, which is a marker, it's not the same as what you were talking about. It's a marker of involvement, participation more broadly. We still find a benefit, but what we do when you look at the individual studies that have looked at involvement, just like you're saying, just like anything, you know, the more involved you get in treatment in AA, the better you do. So the three things that we do find that show a benefit is going to meetings. At least 3 meetings a week is associated with complete abstinence, 3 or more meetings a week on average, complete abstinence. Having a sponsor, somebody who's mentoring you, monitoring you, someone you're accountable to every day, and talking at meetings is the other one, interestingly. Just verbally participating. It reminds me of one of my old supervisors at the VA in San Diego, where I went to grad school at UCSD. He would always say to the veterans, you know, come on guys, you got to talk. If you don't, this is talk therapy. If you don't talk, there's no therapy. And it's the same thing as you're implying, you know, if you go to the gym but you don't work the equipment. If you go to AA but you don't talk, you don't benefit as much. You still benefit, but you don't benefit as much. These are kind of additive benefits. So just like anything else, you're absolutely right. What we see when we look at studies of involvement, you get much more out of it. You get much more benefit.
Thank you for that. This is our last question. No
Okay.
pressure, but make it a good one.
Oh, I was already nervous. So, okay. So Lexi, and I'm the executive director of the Steve Remler Hope Network. So grateful for all your time and your dedication, and for everybody here, and for you guys putting this on today. Thank you. So Senator Eaton is sitting here with me, and she's got a piece of legislation moving through a bill through the state Senate. I see Representative Dean over there too. And this legislation that's proposed is going to create, which will pass this year, is going to create roughly $15 to $22 million, I see Claire laughing at me up there, in new revenue. So my question for you is, there are so many solutions. Most people in this room know what the solutions are. What's the one thing that each of you on the panel would say to our legislators to have them pass this bill so that we have the funding in place to create these solutions? What's the one thing you'd say to them to move them? And 2, what would you want that money to go towards in creating the solutions? So, and then FYI, for everybody here, we have Opioid Day on the Hill, the second one, on March 1st. So please come. Okay, thank you.
What would I say to try and get them to pass the bill?
You just want it to be smart, like, oh, I just have one thing to say.
I'm an economist, right? I talk numbers. So here's what I'd say. You know, as a person, as an investor myself, if I can get a return of 5 or 6%, I'm thrilled. Of business, they take on risk. If they can get a 10% return, they're pretty excited. The kind of things we're talking about here, you spend $1, you get at least $12 back in return, 1,200% return. It's the kind of thing any person would love to have an opportunity to invest in. And well, as politicians, you have that opportunity. I wish you could do more than 22 million, but it's a return that will handsomely reward you and repay itself very quickly. So I encourage you to do it.
I'd probably just bring Mark up to the Capitol. That was beautiful.
I would say exactly what we had said before. The #1 killer of us Americans under 50 is opiates. And, you know, we all talk about the number of deaths, which in this country for addictions, I think is 64,000 and 44,000 are from opiates. But the number of near deaths is 3 times that amount. What I would say is that brings it close to home. We act if it touches our families. And I bet, I mean, I know, I don't even want to bet because I know, and it would be taking money from a child, that every one of the legislators somehow is personally involved. And that's what they have to hear.
Yeah, go ahead.
No, I was just, I mean, I didn't mean to give a flip answer. I mean, I would say what Mark said in terms of the investments. But then I would also really encourage that these investments go both towards specific strategies and treatments for the opioid crisis and continue to strengthen the entire continuum of care. Because again, this is a very, very severe crisis, and we're seeing meth on the rise and alcohol. I mean, and just also assuring that we are treating the mental health system at the same time as the addiction system, because as we talked about, you really, the amount and the evidence of co-occurring is overwhelming. And so we have to continue to invest and pay attention to these systems as they grow together into healthcare.
Yeah, I think I would just make the same point. I like Mark's point on the economic savings. That's an important part of it when you're talking to legislators. Again, I'd make the infrastructure point. You know, we're spending all this money on infrastructure for the safety and well-being of Americans, but we've got this right in our face right now, where so many people are dying right now, more than motor vehicle accidents, more than gun deaths combined, to make the moral case for families, Americans that are losing people every single week. And also, even perhaps more important for legislators is the economic case, as Mark pointed out. Hate to say that, but what people are very interested in is how we can save money. And these are very cost effective, as Mark quite rightly says. You know, $1 invested saves roughly 12 in lost productivity savings, healthcare costs, and criminal justice savings. That is a huge return on investment. I think people just don't connect the dots there in terms of when you provide these resources and services, proper accounting for the savings in these other areas. That's where I think it gets missed a lot of the time. When they've done economic studies, this is the kind of ratio we see, but I think legislators and politicians don't always take the time or aren't presented with the data in such a way that those dots are connected. That needs to be analyzed locally so you can see a benefit in the Minnesota level. So you can say, yep, this is what you're going to get. Let's measure it over 5 years. Let's realize, let's become aware of these cost savings, not just a moral argument, which is very powerful and enough in my view of it in and of itself, but the economic argument is very powerful, I think, for legislators.
Well, thank you very much. Thanks for the great questions. Big thank you to our panel. Thanks.